of life issue anymore. It's actually a warning sign of cerebrovascular or cardiovascular disease. And it is considered as early manifestation of coronary artery disease and peripheral vascular disease. And this is very important when you see a patient with erectile dysfunction. You should investigate other peripheral vascular and coronary artery problems. For the epidemiology, of course, the first large-scale community-based study of erectile dysfunction was the Massachusetts male aging study, and it revealed the prevalence of 52% of men in 40 to 70 years old with erectile dysfunction. This means that almost half of all men above the age of 40 will suffer from erectile dysfunction. This is the recent study. Of course, the Massachusetts male aging study, it was in the last century, but this is the recent study almost 2 months ago has been published in the Sexual Medicine Reviews, and it is present in 8 countries. It is the epidemiology of erectile dysfunction in 8 countries with high burden: Italy, France, China, Spain, Germany, US and UK and Brazil. And we see here that erectile dysfunction is almost from 40 to 50% prevalent in all men in these countries. The same almost like Massachusetts male aging study. So the erectile dysfunction has the same risk factors as cardiovascular disease, whether there's a lack of exercise, obesity, smoking, hypercholesteremia, and metabolic syndrome. So when you see a patient with erectile dysfunction, you have to search for underlying heart disease. Of course, we all know the causes of erectile dysfunction. Into two major causes, psychogenic and organic. Psychogenic almost 10 to 15% of the cases, while the organic is mainly the vasculogenic erectile dysfunction, and in other cases, the neurogenic, endocrinal, anatomical, and drug-induced. The psychogenic erectile dysfunction is divided into 2 groups, the generalized type and the situational type. Generalized type, like the lack of arousability and disorders of sexual intimacy, and the situational type is mainly related to the partner or the performance. The causes of erectile dysfunction, which are organic, are divided into vasculogenic causes and mainly related to the ischemic heart disease, cardiovascular disease, hypertension, diabetes, hyperlipidemia, smoking, and of course, we all know the major surgery, pelvic surgery, like in radical prostatectomy or radiotherapy in the pelvis. Also, the neurogenic causes of erectile dysfunction can be classified into central and peripheral causes. The central causes like multiple sclerosis, tumors, Parkinsonism, spinal cord disorders, and peripheral causes, also the diabetes is condemned, alcohol, uremia, polyneuropathy, and of course, surgery in the pelvis like radical prostatectomy. Another type of causes for erectile dysfunction is the anatomical or structural causes of erectile dysfunction, where there is a disease in the penis itself that causes it, that prevents it from erection, like Peyronie's disease or penile fracture, if penile fracture causes venous leakage, sometimes in crippled hypospadias and epispadias and micropenis where multiple surgeries are usually the consequences. The erectile dysfunction usually occurs after these multiple surgeries. Other causes are the hormonal, where the most commonly the hypogonadism and the hyperprolactinemia. However, the hyper and hypothyroidism and Cushing disease also can be the cause. Of course, we all know the drugs that can induce erectile dysfunction, like antihypertensives, antidepressants, antipsychotics, antiandrogens, antihistaminics, and recreational drugs like heroin, cocaine, and methadone. The diagnosis of erectile dysfunction mainly it depends on the medical and sexual history taking and focus physical examination.
دكتور
When a
محمد
patient
لو سمحت قرب المايك شويه عشان عاوزين الصوت يعلى عن كده شويه.
اوكي كده كويس.
كده احسن.
طيب patients with erectile dysfunction should be evaluated by taking very thorough medical and psychosexual history with the use of validated instruments like the IIEF or International Index of Erectile Function. And this sexual history can identify the sexual problems other than ED and identify the causes of the erectile dysfunction, the risk factors for ED, and you have to assess the psychosocial status of the disease. This is the main value of medical and psychosexual history. Then focused physical examination should be tailored to detect any penile deformity, any prostatic disease, any sign of hypogonadism, and generalized cardiovascular and urological status. So the first step is detailed medical psychosexual history of the patients. In sexual history, you have to ask about the previous and current sexual relations, the current emotional status, the onset and duration of erectile problem, the previous consultations and treatment, and whether there is morning erections or not, where there is a problem also with the arousal, ejaculation, gas. You have, I encourage every urologist to have the International Index of Erectile Function at his clinic for all patients, like the IPSS for the LUTS. Because the IIEF, you can assess all the function, all the sexual function domains of the patient, whether the erectile function, the orgasmic function, the desire, sexual desire, and the intercourse satisfaction and overall satisfaction. It's available online, and it is about 15 questions. The erectile function domain starts by first five questions with the 15 question. The intercourse satisfaction domain with question number 6, 7, and 8. The orgasmic domain with question number 9 and 10. Sexual desire domain with question number 11 and 12. And overall satisfaction domain with question number 13 and 14. The abbreviated questionnaire, it is called the SHIM score, or Sexual Health Inventory for Men. And actually, only five questions from the are included in this question number 5, 7.
الصوت بيقطع.
بروف عبد الرسول، في مشكله في الكونكشن عندك، يا ريت بس تشيك عليها.
طيب انا هحاول ثواني كده.
وممكن حضرتك تشغل الكاميرا عشان الكاميرا مقفوله.
كده احسن.
كده احسن.
كده الكاميرا مقفوله.
الكاميرا مقفوله. دوس على الكاميرا، دوس على الفيديو هتلاقيها اشتغلت. تمام كده يا بروف، اشتغلت.
كده اوكي.
كده تمام.
Okay. The diagnosis, as we said, depends on the history and the physical examination, which focuses on the urinary, endocrine, vascular, and neurological symptoms, especially the blood pressure, heart rate, and signs of cardiovascular disease. While locally, you have to search for Peyronie's disease, prostatic enlargement or cancer, any sign of hypogonadism like small testes, alteration in the secondary sexual characters, diminished sexual desire, and changes in the mood. Any patient with age more than 50 years, you have to do digital rectal examination. So after history and examination, you can do laboratory tests. We have only 3 tests that can be ordered for erectile dysfunction patient: the glucose and the lipid profile and the total testosterone. In all patients, you have to do these 3 tests: fasting blood sugar, lipid profile, and morning sample of total testosterone. However, if you suspect hypogonadism, you have to do testosterone. And if the testosterone is low, so you can do additional hormonal tests like prolactin, FSH, and H. Of course, in patients with suspicion of prostate cancer, you have to do PSA. Another important thing when you evaluate a patient with erectile dysfunction is you have to categorize this patient, whether he's low risk category for cardiovascular disease or high risk or in between. The low risk category is asymptomatic patient. He has less than 3 risk factors for coronary artery disease, mild or stable angina, uncomplicated previous myocardial infarction, controlled hypertension, mild viral disease. All these are considered low risk category. However, the high risk category can have high risk arrhythmias, unstable angina, uncontrolled hypertension, and moderate to severe valvular disease. Anything in between are considered intermediate risk. So when you assess the patient as low risk category, so no need for cardiac evaluation. And you can give the treatment no problem without any consultation to the cardiologist. However, in intermediate risk patient, cardiology consultation is very important. And in high risk category, don't give him any treatment. And this patient should undergo cardiac assessment treatment before any sexual activity. For the diagnostic tests, actually, not all patients need diagnostic tests. There are indications for specific diagnostic tests, like in primary erectile dysfunction, which is not caused by any organic disease, in young patients with pelvic trauma, in patients with penile deformity, which may need surgical correction, like Peyronie's disease, in patients with complex psychiatric or psychosexual disorders, patients with endocrine disorders, and in medico-legal reasons, if you are going to consider implantation of penile prosthesis implantation. What are the tests that you need to do in erectile dysfunction patient? Mainly 2 tests: the nocturnal penile tumescence or the Regis scan, and the penile duplex. However, the ICI test is now not universally accepted to be done, except as a part of the penile duplex. And the other vascular studies like dynamic infusion cavernosometry and cavernosography and the internal pudendal arteriography are only done if you're considering doing the penile revascularization surgery. However, you can do, of course, endocrinological study if you're suspecting endocrinal problem, and psychodiagnostic evaluation is mandatory if you suspect psychological problem.
Prof. Abdul-Rasul, some doctors raise their hands. Can they ask now or after the
I prefer that they write down their questions, and then
after the end of the lecture.
Answer them at the end.
Okay, okay.
Okay. The Digiscan is a device that can be given to the patient at home. It needs at least 2 nights. These 2 rings are placed, one at the base of the penis and the other on the tip of the penis, and this along the whole night records the rigidity at the base and at the tip. And the erectile events of at least 60% rigidity at the tip that lasts for 10 minutes or more is normal. Anything less than 60% at the tip is not considered as normal, and this is to differentiate between the organic and psychogenic erectile dysfunction. As I said, the intracavernosal injection test has limited information, and it is now done as a part of the penile duplex ultrasound study. The technique of penile duplex, some measures have to be considered, like reassurance, quiet room, intracorporeal injection with self-stimulation, and you do the duplex ultrasound every 5 minutes till 30 minutes. Normally, the peak systolic velocity will be more than 30 centimeters per second, and the end diastolic velocity less than 3 centimeters per second. In arterial disease, the peak systolic velocity is less than 25, and in venous or veno-occlusive dysfunction, the end diastolic velocity will be more than 6 centimeters per second. However, there are mixed parameters, as you see. This is a normal duplex where there is a spike, peak systolic more than 30, and the end diastolic, as you see, is reversed, less than 0, actually. This is the normal. This is a patient with venous leakage where the end diastolic is more than 5 centimeters or 6 centimeters per second. And this patient has arterial insufficiency. As you see, the peak is not reaching 20 centimeters per second. This is another case of venous leakage where the end diastolic, as you see, is more than 6. However, the arterial peak systolic is okay. So this has veno-occlusive dysfunction. This is a patient with mixed arterial and venous. The peak systolic is less than 30, less than 25, and the venous is already end diastolic more than 6. As I said, the bilateral selective internal pudendal angiography are usually done only if fracture pelvis and you're going to do the penile revascularization surgery. Also, the dynamic infusion cavernosography and cavernosometry is now limited to patients for before vascular reconstructive surgery, to exclude that there is the venous leakage, or you can define the part of the veins that is leaking. Okay, now after investigation, after the history, examination, and the proper investigation, now we are managing the patient with erectile dysfunction. Actually, this is the guidelines in 2019 in the European guidelines in 2019, and this is the European guidelines in 2020. The same, you have to make the comprehensive medical and sexual history, and before anything, you have to do lifestyle changes and risk modification, and treat the curable causes, and provide the education and patient counseling and his partner. This is the very important before giving any treatment. And then you discuss with the patient and his partner the multiple options. Okay, all the options, whether intracavernosal injection, oral treatment with PDE5 inhibitors, the vacuum device, and topical or intraurethral alprostadil, which is not available in Egypt, actually. The same scheme here is the same scheme on the last year. However, there is one thing that has been added up to date in these guidelines in 2020 is the low intensity shockwave therapy. It is now one of the armamentarium of the tools that we can treat erectile dysfunction as approved by the guidelines. However, this guideline is still just a moment. I'm sorry. However, this recommendation is still weak, but with growing evidence, I think the next years will be with a strong recommendation. The treatment of erectile dysfunction, as we said, starts with lifestyle modification. Of course, the obesity and the exercise, everything should be managed as ischemic heart disease. There are curable causes of erectile dysfunction, like hormonal treatment in patients with hypogonadism, with testosterone replacement therapy, and of course, in arteriogenic erectile dysfunction with the young patient with post-traumatic fracture pelvis. These patients have very useful benefit from the penile revascularization surgeries with 60 to 70% long-term success. The first line treatment, of course, we all know the oral pharmacotherapy with PDE5 inhibitors with the three sildenafil, tadalafil, and vardenafil. However, the avanafil has been added as fourth line of PDE5 inhibitors. They are all the same, except that tadalafil, of course, we know that it has very long half-life. However, the side effects of the avanafil are very minimal, and of course, tadalafil and avanafil, you don't have the problem of dyspepsia or fatty meal. Now the monotherapy with tadalafil and 5 milligram has been added in the LUTS management of BPH. And this is the largest randomized control study with platinum priority in the European Urology, has been published in 2012. And it shows that both the tadalafil and tamsulosin have the same effect on obstructive symptoms due to BPH. And with the recommendation of the 2020 European guidelines now is you can use phosphodiesterase type 5 inhibitor in men with moderate to severe lower urinary tract symptoms with or without erectile dysfunction as monotherapy. Of course, we all know the vacuum constriction device and its problems. And the intracorporeal injection, sometimes it is useful using the papaverine, phentylamine, and sometimes you use the prostaglandin alprostadil or the 3-by-trimix. The Muse is not available in Egypt. However, it is a medicated pellet, give it intraurethral. However, it has local side effects like pain, dizziness, and urethral bleeding. The third line treatment is, of course, the penile prosthesis, and they are not the scope of our talk today. However, I will talk some of the slides, the coming slides, about the low-intensity shock therapy and what we know about them till now. I'll try to highlight the scientific basis of the low-intensity shockwave therapy, the animal studies that had been done, the human studies, and what are the future perspectives. The scientific basis of low-intensity shockwave therapy depends on the stem cells. Of course, we know that we have over 100 trillion cells in our human body. In normal tissue, cell proliferation is restricted to cells that replenish the tissues, which are the stem cells. So the stem cells are self-renewing cells that can divide asymmetrically to yield a new stem cell and a progenitor cell. These progenitor cell may undergo further divisions, ultimately leading to terminal differentiation. And once these cells have terminally differentiated, they are no longer divided. So the stem cells are classified into circulating stem cells and resident stem cells. Circulating stem cells like the endothelial and mesenchymal and bone-derived cells and adipose tissue-derived cells. They are circulating all over the body. However, there are resident stem cells that are present in every tissue, in the derms, like in the hair follicle, striated muscle like the stellate cells, in a smooth muscle like in the penis, on the bladder or the urethra. The spermatogonia are considered as resident stem cell, intestinal mucosa, of course, and the fibroblasts. So the idea of the low-intensity shockwave therapy is, since stem cells exist all over the body, can we activate them locally inside you? I mean, if there are stem cells here, can we activate them locally here? Can we do this magic? Just some shock waves on the penis that activate the stem cells here in the penis and make the miracle happens? Shock waves make new vascularization. Of course, we all know the extracorporeal shockwave therapy. as urologists, we were the first to use the shockwave in stone fragmentation in the early 80s. And then the orthopedics used the shockwaves in 90s. And then the cardiovascular specialists used the low intensity, very low intensity shockwaves in the early years of this century. And then only a few years back, the andrology or urology has used this low intensity shockwave therapy in the treatment of erectile dysfunction. What is a shockwave? A shockwave is a longitudinal acoustic wave that is consists of a short pulse, very rapid pulse, very high intensity, almost 100 megapascal, in very short time, rise time in only 5 to 10 nanoseconds, and then followed by very rapid, slow reflection of the shock wave till below 10 megapixel. This shock wave can affect every part of the cell, from the cell membrane and the endoplasmic reticulum, the mitochondria, of course, it is the powerhouse of the cell, and the nucleus. Many studies has been done on the cellular signaling pathway modulating this low intensity shockwave therapy. Most of the receptors are present on the cell membrane, where the low intensity shockwave therapy activate these receptors to go to the cell nucleus to activate certain genes leading to stem cell proliferation and tissue regeneration. Also, these are another receptors for the low intensity shockwave therapy inside the endoplasmic reticulum membrane. The mechanism is still unknown. However, the shockwave can make micro trauma by these bubbles inside the vessels, and this micro trauma activates the stem cell of the nerves, which is the Schwann cell, and the stem cell around the vessels, leading to neovascularization, and also the stem cells of the smooth muscles cells, leading to new endothelial revascularization. The basic research done by Tom Lu has been published in 2019, where smooth muscle differentiation of the penile stem cells has been induced by the shock wave. These are the control cells, and these are the cells after putting the shock waves. After 1 day, smooth muscles has been produced. On the 3rd day and the 5th day, more smooth muscles has been produced by the stem cells, and you can see here the amount of the smooth muscles has been increased. This was the in vitro studies. However, the animal studies, also by Tom Lu, has been published in 2017, where in situ activation of the progenitor cells with low intensity shock wave on the mice, on the penis of the mice, has been shown that more stem cells has been migrated to the penis from the these are the control, and these are the induced by shock wave cut section of the penis. The sham has no smooth cells, smooth muscle cells. However, those has been induced by low intensity shockwave therapy, has been shown that many improvement in the smooth muscle and the new vessels. Also, this is the normal control, and this is the mice after cutting the pudendal nerve. And this, when this mice has been exposed to the low intensity shock wave, as you can see, the pressure has been increased intracavernosally. So by the animal study, we can see that endothelial cell proliferation can give angiogenesis and neovascularization. Schwann cell proliferation leads to nerve regeneration, and the smooth muscle proliferation leads to smooth muscle regeneration. What about the human studies? Actually, this is a systematic review and meta-analysis of the whole randomized control trials upon the low intensity shockwave therapy, and has been published in the last year. A total of 28 clinical studies, 14 were cohort studies, and 14 were randomized control studies. More than 2,000 patients. And the assessment was subjective and objective. These are subjective by the IIEF and the objective by the erection hardness score and by the penile duplex. And as you see by the meta-analysis, that all of the studies conclude that there is a difference in the IIEF towards the treatment group with shock waves. Also, there is a minimally clinically important difference in the favor of the shockwave therapy. Also, the erection hardness score, which is objective, is with the shockwave therapy. And by duplex, there is marked significance towards the shockwave therapy. There is also the mean difference in the International Index of Tract Function in the treatment protocols towards the towards the shockwave therapy. So there is a subjective and objective evidence of the efficacy of shockwave therapy, and that's why the European guidelines now has been advocating the use of low intensity shockwave in erectile dysfunction patients. However, after 10 years of intensive clinical research and several answers has been very important, still missing. The best candidate for low intensity shockwave, this cannot be answered till now. What is the best device? What is the source of shock waves? What is the optimal treatment protocol? What is the anatomical areas of corporal coverage? The number of sessions, the amount of energy, how long does the effect last? This puts our society in charge to make future studies that to have to answer these questions. Thank you.